Hi, my name is Rachel Connor, and I'm a fourth-year osteopathic medical student from OUHCOM, and today I'll be presenting a case called Ovarian Metastasis of Renal Clear Cell Carcinoma, a rare case report. Clear cell renal carcinoma is the most common type of renal cancer, with about 60,000 new cases diagnosed annually in the U.S. The 5-year survival rate ranges from 50 to 69%, but drops significantly to about 10% if metastasized. Risk factors include obesity, smoking, hypertension, kidney disease requiring dialysis, genetic factors like VHL disease, and environmental exposures. Common metastasis sites include lymph nodes, lungs, liver, bones, adrenal glands, and the brain. Metastasis to the ovary is extremely rare, with only a few documented cases. Ovarian metastases are more commonly from colorectal, breast, lung, stomach, and pancreatic cancers. So this case is unique because ovarian metastasis from clear cell renal carcinoma is exceptionally rare. This case presentation is a 72-year-old female presenting to her OBGYN with progressive low back pain and abnormal uterine bleeding. Her past medical history was significant for GERD, hypertension, asthma, arthritis, obesity, and kidney stones. She had a family history significant for ovarian cancer in a maternal aunt, heart disease, and hemochromatosis. She has a history of multiple surgeries, including an appendectomy, cholecystectomy, and heart catheterization. She's a non-smoker with no history of drug or alcohol abuse. An ultrasound was performed due to abnormal bleeding and revealed a thickened endometrium, prompting a hysteroscopy with dilation and curettage. Hysteroscopy revealed a proliferative endometrium, and due to her postmenopausal status, a total hysterectomy with right salpingo-oophorectomy was performed. Pathology results from the uterus were negative, but the right ovary had a metastatic clear cell carcinoma. A follow-up CT showed a likely metastasis from the right kidney, which revealed a 4-centimeter mass. Further imaging was negative for additional metastases. A right radical nephrectomy was performed, and the patient was started on adjuvant pembrolizumab, but later switched to cabozantinib due to immunotherapy-induced myocarditis. Here you can see the coronal CT view, which shows a 3.98 by 2.85 centimeter complex mass on the inferior lateral aspect of the right kidney. The axial CT confirms a 3.09 centimeter mass in the posterior lateral region of the kidney. This imaging supports the metastatic spread from the kidney to the ovary. Currently, the patient is disease-free, but at high risk of reoccurrence. Limited literature makes prognosis and treatment challenging, and more research is needed to understand ovarian metastasis etiology and improve prevention and treatment. Renal cell carcinoma typically metastasize to the lungs, bones, liver, and brain, making ovarian involvement exceptionally rare. This rarity is likely due to the mechanism of metastasis. The most probable route in this case is hematogenous spread, as renal cell carcinoma is highly vascular and tumor cells can travel through the renal vein to the inferior vena cava, then to systemic circulation, then to the ovarian arteries. Lymphatic dissemination is another possible route, but is less likely, as renal cell carcinoma primarily spreads to the retroperitoneal lymph nodes rather than into the pelvis. And direct extension is rare unless there is peritoneal invasion, which was not seen in this case. The ovarian microenvironment may also play a role in metastatic tropism, although this is not well understood. Recognizing these patterns is crucial for early detection and guiding treatment strategies in rare metastatic presentations of renal cell carcinoma. Diagnosing ovarian metastases from renal cell carcinoma is challenging due to nonspecific symptoms. This patient presented with abnormal uterine bleeding and low back pain, which is more typical of primary gynecologic conditions. Key differentials included primary ovarian clear cell carcinoma, which is histologically similar to metastatic renal cell carcinoma, as well as metastases from other primary cancers such as gastrointestinal, breast, or lung. Diagnosis relied heavily on imaging and immunohistochemistry, and histopathology confirmed clear cell carcinoma of renal origin, emphasizing the need for thorough evaluation of ovarian masses. Treatment of renal cell carcinoma with ovarian metastases involves surgery and systemic therapy. Nephrectomy and pembrolizumab are standard, with surgery preferred for isolated metastases. A challenge was myocarditis from the pembrolizumab requiring discontinuation. This case highlights the need for careful monitoring with early intervention leading to a disease-free outcome. In conclusion, this case emphasizes the rarity and diagnostic complexity of ovarian metastases and renal cell carcinoma. It highlights the importance for multidisciplinary collaboration and management and shows the need for further research to improve detection and treatment strategies. Here are my references. Here are my acknowledgments and authorship. And if you have any questions, please feel free to email me, and thank you for your time.